and gentlemen, distinguished guests, doctors, professors, good evening. My name is Kai and I'll be your MC for tonight. Welcome to this evening's symposium on the topic of the role of breast cancer registries in prevention and control, co-organized by the Center for Global Health from the Chinese University of Hong Kong and the Hong Kong Breast Cancer Foundation. And this event is kindly sponsored by Roche Hong Kong. So let's give them a round of applause. It is our great pleasure to have invited Professor Kirsten Sandelin from the Karolinska Institute, Stockholm, a renowned specialist in the field of breast cancer surgery and research, as well as Dr. Polly Chung, specialist in the area of breast and endocrine in Hong Kong. Dr. Polly Chung has been a pioneer in the Hong Kong medical community in establishing many breast cancer-related initiatives and raising awareness about them in the public sphere. We hope that the sharing of experience in the Swedish and Hong Kong National Breast Cancer Registries will generate meaningful discussion regarding the ways in which the collection and surveillance of this data may improve health outcomes for our breast cancer patients. This evening, we also have the honor of having Professor Sophia Chan, under the Secretary of Food and Health for the Hong Kong SAR government, to be our guest of honor this evening. Before we start, may I please invite Professor Sophia Chan to deliver a welcoming speech. Professor Chan, please.
Thank you. Dr. Polly Chung, Professor Sandelin, distinguished guests, ladies and gentlemen, good evening. It is indeed my great pleasure. Thank you, Polly, for inviting me to this distinguished occasion where we can all enjoy your talk and also Professor Sandelin's talk on looking at the role of breast cancer registries in cancer prevention and control. I'm sure this talk will be highly stimulating, and then it will be also thought-provoking and get us all together to think about the way forward. Indeed, the importance of cancer registries in influencing healthcare strategies and also decisions, not just in Hong Kong, but throughout the world, is becoming increasingly apparent. The systematic collection, analysis, interpretation, and also reporting of data enables a better understanding of the nature and also extent of the disease burden on a community. It provides crucial information to governments for enhancement of healthcare policies, for effective disease control, and also enables the public to better defend themselves against the threats of diseases. Hong Kong can appreciate this firsthand through our experience with the Hong Kong Cancer Registry, established by the Hong Kong government in 1963. The Hong Kong Cancer Registry is a population-based cancer registry collecting information on cancer cases within the territory. Under the management of the Hospital Authority, the registry currently records information from over 500,000 local cancer cases. These statistics have enabled us to identify the top 10 cancers affecting the population, as well as the threefold increase in cancer cases from mid-70s until the present day. Most recent figures actually show that over 26,000 new cases of cancer are diagnosed each year in Hong Kong, and there are about 12,000 cancer-related deaths per annum. Further research indicates that these figures will increase given the aging and also the increasing population of Hong Kong. The Hong Kong Cancer Registry has also informed on the changing landscape of cancer trends in Hong Kong, facilitating the government's healthcare policy decisions on resource allocation as well as disease control. I'm very pleased to see that Polly, as well as who have invited to Professor Sandelin of the Sweden's very famous Karolinska Institute. Both of you are experts, in fact, experts in the field of breast cancer. And this evening, I'm sure it will provide us all with a very valuable opportunity for information experiences, best practices, sharing, exchanges, and I hope it will spur further discussion and also exploration of how we can leverage the information provided by the breast cancer registries in Hong Kong towards protecting the local population against the disease. And finally, I would like to thank the Hong Kong Breast Cancer Foundation, Imperial Poly, the leadership, and also the Chinese Universities of Hong Kong for jointly hosting this evening symposium and providing such an excellent forum for our exchange and also further discussion. Thank you very much.
Mr. Chan, you may now be seated. Now, it is my great honor and privilege to introduce our keynote speaker for tonight. Professor Sandlin is a professor of surgery at the Karolinska Institute in Sweden. She is also a practicing breast surgeon, currently serving as a senior breast consultant for the Karolinska University Hospital. In addition to holding multiple professional qualifications, she is an examiner both locally and regionally for breast surgery specialist accreditations. She has sat on the editorial and reviewing boards for many well-established and peer-reviewed medical journals. Her extensive clinical research led her to begin the regional breast cancer registers by helping to develop surgical quality indicators in the 1990s. This work subsequently led her to involvement in pioneering, establishing, and running the National Register in Sweden. Overall, her extensive experience in the academic, clinical, and policy settings makes Professor Sandlin a renowned specialist in the field of breast surgery, both in Sweden and internationally. And we're now incredibly excited to have her here with us. Ladies and gentlemen, Professor Sandlin.
I am extremely honored, and thank you for those very, very kind words. And again, I would like to convey my gratitude and thanks, first of all, to Polly, because you are a fantastic person and a long-standing friend who has made this possible, and of course to the University of Hong Kong, the Chinese University, and the Hong Kong Breast Cancer Foundation, and also Roche. So again, I'm really honored to be here and share with you some of my slides who should put together a little bit about the work we have been doing the past years, and also, I think, importantly, to make some comparisons with our both registers, because as a national register, the Swedish register and the Hong Kong register have the same age. So this is where I come from the Karolinska Institute, with the new aula being built, and it's leaning towards the new hospital, which is going to be built, and well, it's almost being there in a couple of years. And you can see Sweden there with its flag, and between the long axis, it's 2,000 kilometers. So it's a country with scarcely populated in the north, most centered in the south. Sweden has about, so I need to give you a little bit of background. Sweden has about 10 million inhabitants. We can see, and this is from the register, that now currently 50 hospitals perform breast surgery in Sweden. In Stockholm, we have actually 4 hospitals for about 1,800 cases. We have a ruling of national and self-governing in the 20 county councils, which means that each council has actually a political power to decide on healthcare. There is also the Swedish Association of Local Authorities and Regions, and they are actually serving as advisory board both for organizations and healthcare providers. So that's another force which actually has been a tremendous effort and help for the development of the cancer registers, or the quality registers, I should say. I heard now that the Hong Kong cancer register is quite old. The Swedish one was actually established in the late 50s and gets about 50,000 new cases per annum. Now, I think that before going further, I need to sort of say something about the screening, because many perhaps will make a resemblance of Sweden and mammography screening. This is something which has become a very natural part of our life, because when the study came out in the late 70s, proving that the group of invited women for mammography screening actually had, within quite soon, they were discovering a lot of breast cancer, and they could look at mortality rates which were decreasing. This took so much to the Swedish population that national screening was introduced and recommended by the Ministry of Health and Welfare. Many of you have probably seen and talked or attended Laszlo Tabar's many courses. He has really devoted his life to mammography screening, and he is an avid proponent of mammography screening. Also, keeping in mind that if you discover a small cancer, and usually he sets the size of about 14 millimeters, you have really got a very good chance of curing the woman. And also some of the critique which has been raised for the non-invasive cancer, we should bear in mind that every second recurrence will be an invasive cancer after a carcinoma in situ. You can see on the top picture is a mammography bus, because Sweden is sometimes quite scarcely populated, so you need to have buses that move around like mobile units where women are summoned. We do have national screening from 40 to 74 for the women in the age group 40 to 49. Every 18 to 24 months, and for the women in the older age group every 24 months. You can see that the national compliance is around 75 to 80%, and of course in the urban area there is a lot of what we call opportunistic screening. That is that women will go to their gynecologist or someone else to have their mammograms. But also, you need to bear in mind that this is more costly, more radiation, because a clinical mammography encompasses also more pictures. So that's another difference. We had a national inquiry for a cancer strategy in 2009, and I was fortunate enough to be part of that. That was actually an inventory of cancer care in Sweden. And just to sum it up, it showed that Sweden actually had fragmented care, and there were unexplained regional differences. So the mission from this inquiry was that cancers should primarily be prevented from a public perspective. But not only that, also from the patient perspective. And that was one thing that was found, that a person with a breast cancer would be almost tossed around by many different specialists, because many of the cancers are chronic, like breast cancer. And another thing which actually came out of the national inquiry was the formation of regional cancer centers, and they would be coordinators of cancer care. So today we have 6 regional cancer centers, and they are also individually responsible for the different cancer registers that are now in function. About 95% of all cancers do have a cancer registry. and or a quality registry, I should say, because these registers are person-based in contrast to the cancer registry, which is tumor-based. And the cancer registry is by law is a prerequisite to register. All primary cancers should be registered, whereas the quality register, you opt out. Ethically, it has been considered more beneficial than harmful, and therefore all patients get written information that their data is entered into a quality register. But should they wish to opt out and have their information withdrawn, that will of course happen. It does happen quite rarely, and I don't know how it works in Hong Kong. If many of the women do opt out, do they, Polly? You opt them in. That's good. Yes. Well, to make this story a bit comprehensible, I told you about the Swedish Cancer Registry, which founded in '58, and that of course covers the whole population. It's a legal requirement. But we have this thing about our birth certificate, and you can see that actually takes us everywhere. And it gets a little bit impersonal, to be honest, because if you go to a bank, you go to an office, you call for anything, the only thing the person is interested in is your unique person ID, and that is the figures of birth. So you can see now exactly when I was born in 1952, 3rd of July. But I do have a unique serial number, which is 0221, and it also says that I am a female, the third figure. So that actually was helpful when the regional reports were existing. And they actually existed for, as you can see, for 30 years. Regional reports in many of the cancer specialists, but for breast cancer, which was the pioneer, the first register was done in 1976. And of course, a lot of knowledge has come out of that. And probably, therefore, it was not that difficult to get everyone on board when we started on our national reports. As you kindly said in the introduction, we started with surgical quality indicators in Stockholm. And when we presented that on a national basis, everyone got really excited and said, well, this has never been reported before, so I think we should make a joint effort in the country to form the report. So since then, we have produced national reports. As you will see, and as I thought I promised to give you 2013 data, I have to admit this is not possible because the enormous work to validate and to get all information has not yet been possible. So what I will share with you are the 2012 data. I did put up your registry because I think they really do share a lot of important similarities. You can see that the organization is quite similar. You do have a steering group and you do have patient representative, which we find is extremely helpful and good. We have until now only had one representative, but in October, when we had a steering committee, it was proposed by the organization of patient representatives in quality registers that each register should actually have 2 members, because one member from the lay can feel quite lonely. And I think that you actually can strengthen each other, and you can actually do a lot of collaborative work. So we're very, very happy now that we have 2 patient representatives in our steering group. One difference is that you have a partial completion, but hopefully that will grow. whereas we have about 99% completion. And where it's not 100% is that we may miss those few women who are not operated upon, and they only are registered in the cancer registry, their tumors. You do include quite heavily some epidemiologic data, which we do not have. Our register is built up to describe the breast process from diagnosis and to the first recurrence. So it's actually made of different parts. The first part takes you through the journey of the detection mode, actually the same thing as you have in your register, and then it actually covers in detail the clinical pattern, the way of diagnosis, and the multidisciplinary conferences, the kind of surgical procedures, and also the outcome of that, and the recommended treatment by the multidisciplinary board. And it also includes the quality indicators that are set by the National Board of Health and Welfare. And there we have a very good collaboration, which actually makes the register quite dynamic. And it has actually from its beginning gone through quite a lot of modifications. We have removed variables where we think these are not so much important anymore. For example, a lot of information regarding the sentinel node biopsy, which has now been introduced as such a routine procedure that we found it superfluous to have all this data. You have in the Hong Kong registered patients reported outcome measures, which I think is very extremely valuable and useful for you. This has, we had some surgical indicators, but we are now working from the beginning to include those, and we're doing it in a fashion so that these outcome measures can be actually follow the patient from inception to the first recurrence. We set target levels, and those target levels are both national and international. We follow some of the USOMA guidelines, we follow Europadonna, and the Swedish Surgical Society and the Swedish Breast Cancer Group. And of course, those target levels are also modifiable and will change according to new research results. We can also report on morbidity. You have a very nice glossary, which makes it easy to understand. We were very happy to have the consumer representative that helped us to get a language which could be understood also by lay people, because we hope that those who read this report are not only the professionals, but also other stakeholders that will benefit from understanding, and also the consumers to understand what is actually going on. So we are now introducing a glossary to the register. You are an NGO founded organization, whereas we are government founded. We make applications for money, and we are certified into different degrees depending on the kind of information and completion that we have. And we are hoping to get certified number 1, but that in order to do that we need to have our patient-related outcome measured in place. But we also have now which is something we are very happy about. We have real-time data that we can actually see all the time how the quality indicators are followed. So here you can see the aims of the register, and I think they are pretty much the same as the Hong Kong register. And we feel that this has been extremely important because to allow communication with other caregivers and other stakeholders to follow the trends in management and care. And as you will see, we have seen some changes also during these years. We can compare the trend. And we have actually identified quite a few regional differences which we really couldn't be explained. And that has actually put especially the oncologists together, because we realized that patients in the north would get different radiotherapy than patients in the south, and this was just not really understandable. The same was for endocrine treatment, where some regions had a level of a tumor diameter more than 15 millimeters, whereas others would give any patient with an hormone receptor sensitive tumor endocrine therapy. And as I said, we strive to make the report comprehensive to consumers and to non-professional stakeholders. This is just showing you a little graph about the completeness. And as I said, 99%, 98%, that is for the first part of the register until we lead the patients to the oncologist. Then what we call medicines efter behandling, that is the adjuvant treatment going on. And here we have had a bit of a problem because it is very time consuming, it's quite resource demanding, and also because of the oncologic treatment taking quite a lot of time. And of course we cannot say everything about completeness if you are on tamoxifen, for instance, for 5 years. Then we have the follow-up, which is to report on any first local or regional recurrence. And here has also been a bit of a trouble. So it's not all that glamorous, but the first part mainly made by the surgeons, but also within a much shorter time frame has been really the most successful. We also have a reconstruction register, which we are very proud to see, because reconstruction has been very much underutilized in Sweden. It has been concentrated to the urban areas. Stockholm and Malmö, which is in the southern part, have been the major proponents of offering immediate breast reconstruction. And therefore we set out to make this register to be able to record and to look at the resources needed for immediate reconstruction and oncoplastic procedures at the same time of the cancer operation. But we can also report on late reconstruction after the primary cancer operation, and we had the possibility to assemble all risk-reducing mastectomies in asymptomatic women. So these are the bilateral prophylactic mastectomies that we see. And finally, we have a register which will actually report on the secondary reconstruction, if something went wrong or if something had to be done, or the reconstruction or the oncoplastic procedure had to be redone in any way. So that register actually encompasses 4 forms that you can register. I have to admit that it hasn't, we cannot really count coverage here, because we can only see the hospitals that actually do report. And for the time being, Stockholm is doing quite well, and the southern Sweden, because those are the major centers. But it's also an initiative, and especially for the consumers, to say that every woman, regardless of domestic area, should have the right to reconstruction. So therefore we think that this is quite an empowerment to show the regional differences. Well, here you can see the patients, how we started off in 2008, and in 2012 we had some 40,000, and by now we should have more than 50,000 in the register. You can also see the age pyramid. It has been quite stable. The median age is 65 years and the mean age is 63 years. I think it's a little bit higher than for Hong Kong women. Yes, I can see nodding heads. I'll come back a little bit to the screen-detected cases because our register actually encompasses both invasive and in situ cancers. And because we have such a large proportion of screen-detected cancer, as much as half of the cancers are actually screen-detected. And you can see this has been quite stable during the years, and you can also see that Stockholm-Gotland on the top one, it has a little lower, and that is probably because of the opportunistic screening. And these are all ages, I should say. Now, we can actually look at the resources also for operation, and this slide actually shows you the requirement for patients needing just one operation. These are all invasive cancer, because one of the target levels we said that any woman, not more than 10%, should have to undergo more than one procedure. Then we realized that this was not really fair if you included breast conservation, because there internationally the figures are much, much higher, and we saw that our figures didn't really match up. So we revised that, and so you can see that for women who have had both mastectomy and breast conservation, the majority actually do not have to undergo more than one procedure. And of course you can ask yourself, but is the majority of these cases breast conservation? But you can also see the figures for breast conservation only. But still, the goal of having 10% is maybe not justified when you are talking about breast conservation. And much of our reoperations are due to cancer in situ in the margins. I don't know if you have the same experience. All right, yeah. And those are the cases that we don't know. So we call that new information that we didn't previously know when we reviewed the cases for our multidisciplinary conference. This was what the pathologists found when they did the thorough search. Well, sentinel node biopsy was, we started in the late 90s with sentinel node biopsy, and you can see it has really taken, and as one of the consequences has been that the number of hospitals have decreased because of having not resources to perform sentinel node biopsies. But you can see now that almost 90% of all women do have a sentinel node biopsy done. It's not saying that they only have sentinel node biopsy, but it is part of their treatment. And so we can say that no woman in Sweden today would be denied a sentinel node procedure because of her domestic place to live. Here you can see a trend for post-operative radiotherapy of breast conservation old age. And all our quality indicators would say that all women that would be recommended radiotherapy after breast conservation. And here you can see the figures for the different regions. And those are also the regions where you have the regional cancer centers. And you can see it has been pretty stable, but a little bit of regional differences. This is some information on the subtype of the tumors based on immunohistochemical analysis. And you can see that here we divided it into 3 groups. I didn't translate it because I felt that this is almost understandable for you. You can see the first line, the triple negative, and I think that's in concordance what you should find in your material on invasive cancer. About 7% or 7.6% are triple negative. Does that make sense to your population? You have 12%, okay. In the HER2 negative group, it's about 12% of our patients. I should perhaps mention that the mean tumor diameter in Swedish breast cancer is 12 millimeters. Am I saying no? I'm saying 17 millimeter. I'm sorry. It's 17 millimeter, but it has been stable since we started recording in 2010. What would that be in Hong Kong? All right. Well, but it still means that you are actually catching your tumors very early if they're so small. Yeah. And then you can see the third line. It's the ER positive, the hormone sensitive tumors, those tumors expressing HER2, who are not expressing HER2 and would also be classified as the luminal ACE tumor. And that would naturally actually be the vast majority of our cancers. Here you can look at the post-operative treatment, and I should state that this is what has been recommended, because you saw also that the follow-up for oncology is not 100%, and therefore this is the planned treatment. But we have done some sub-analysis looking at the concordance between planned treatment and given therapy, and it's very high. So usually, because this is in a way ceremonial, following the national guidelines, done within the multidisciplinary context, and where the oncologists will not have an individual treatment, they will actually follow the recommendations of it. So it would only be if the patient would really turn against and say, I will not have that therapy. But there would not be any major changes since this recommendation. And you can see that about 90% of all women who have ER positive tumors also will be recommended endocrine therapy. And here you can see the sort of the counterpart, the patients who have ER negative tumors more than a centimeter or node positive. They are, according to our guidelines, they are candidates for chemotherapy, and you can also see that they are to the large majority. You can see that the darker purple line are the younger is the younger age group, and the brighter purple line would be the total number. And here we did see a couple of years ago that the elder population, and one should perhaps not say elder because it was women over 70 that were severely undertreated, and we still see some regional. But I think the trend is changing, that many of these women in their 70s are very fit, and they do actually tolerate oncologic treatment. Here we come to some of the disparities, and you can see that table is actually showing breast conservation in patients with tumor less than 30 millimeters, which in sort of per definition should be eligible for breast conservation. And here we set target levels. A low level would be 70% and a high would be 80%. And you can see the different regions. And we made actually this quite consistent in order for everyone to see what is actually happening and why is it happening. What is the reason? And we had one resident in surgery who did a survey in the southeast of Sweden, where she couldn't really figure out from the chart or anything why women actually lost their breast although they had very small tumor. It was probably more of the surgeon's view. It was had nothing to do with the distance to radiotherapy, and very seldom it was noted in the chart why the decision was taken. So this will teach us, and this will learn perhaps us to document better why we do, and if we have discussed the issue and the alternative with the patient. We try to do that, and that should be something which should be written in the chart. Here you have patients treated with trastuzumab, which means that they have tumors that express HER2, And you can see that the last majority of all our patients will get trastuzumab. As I said before, about 13% do actually express HER2 in their tumors. So the consequences, as I said, we have seen a concentration when the register started. It was 60 surgical units. We were down in 2012 to 50, and I'm sure that in 2013 it will be around 45. We have about 25 units that will see more than 150 cases per annum, and so there is definitely a concentration. We have also seen that the compliance with the indicators. One example was that a few hospitals actually didn't have multidisciplinary conferences. They thought they had it because the surgeon and the radiologist would discuss the case and say, well, this is a 1.5 centimeter tumor, well, that would be okay for breast conservation. But there was no oncologist, there was no breast nurse, there was no pathologist on board, and now in the register you tick the boxes for anyone present, and the last variable has been the contact nurse that should also be present, and also a given care plan to the patient about it. So we can benchmark and we can look at the differences. We feel it's very important that all these data are transparent. I think we were a little bit reluctant when we started, but because we have the Ministry of Health and Welfare that has something which is called open comparisons for all cancer diagnoses, they will pick our quality indicators, but they will allow us to do some interpretation and to comment. But we work in close collaboration, and we feel that that is important, and we do learn, and we feel that it is for the benefit of the patient. And of course, least but not the last, it's a tremendous source for national collaboration, for introducing new techniques, and of course for doing national studies and to have collaborative research projects, because any research project that wants to use quality register data has to come through the steering committee, where we look through the ethical permits, and we can also alert other regions that this is a study going on, would you like to participate? I should also say, and I did mention that it is continuously modified. Things that are no longer of such importance can be deleted. I mean, it's a dynamic register, and we think that is a key issue. We have to admit it's tremendously resource demanding. I do, as surgeon, I do register a lot of my patients. In other hospitals, you have some data, you have data manager, you have nurse, and it does take a lot of time. And I have to admit, as surgeons, we are not always as meticulous as we should be. When our nurses help us, they do it better, and they are not always happy with us because we don't do it 100% right, which means that they have to go back to the clinical data. And so we have an attempt, and it's a collaboration with, again, with the Ministry of Health and Welfare and the local authorities to get an automatic download of information kept in the patient's chart that should drop down directly into the register. This is a dream, and we hope it will come true. We have made a template for some of the surgical procedures. We have absolutely made a template for the pathologists, because we do have synoptic reporting, and there is, we feel, a question of security, that when you transpose the written form into another written form and then put it down into the register, you can actually provide some faulty information, and that's of course not a good thing for the patients. So this is something which is going on. We are also working on a possibility to use social media to report symptoms. We have one project going on in oncology where patients are actually connected to an app where they can report symptoms, and we hope that perhaps in the larger version that our prompts can actually go into in social media, and whereby patients perhaps can fill these forms in using smartphones, because we know in Sweden that about 70% are connected to social media. So there is a possibility, and we have done a trial and have sent out 200 patients around Sweden, and we actually got 70% back, and about 60% actually handed in electronically their answers. So we know it's working. The thing, Sarah, if you can read it, give me a break. That is a project for child cancer. Child cancer survivors that will be able to communicate with others about their symptoms and about their progress and about relatives. And that is also something which we will use with learning centers. So in order to try and follow through modern technology, but the medical community is sometimes conservative, so it's not done within a day, but we are working on it, and I think it is a must, because the resources to fill all this information is just too demanding. So I think I'll stop there, and I will be happy to take any comments or questions if you have.
Very much. You will now be seated. I know a lot of you are eager to ask questions, but we'll have the Q&A session a little later. Now I would like to introduce our second speaker for tonight. Dr. Polly Chung is the founder of the Hong Kong Breast Cancer Foundation. She has been a notable pioneer for spearheading the issue of breast cancer within the medical community in Hong Kong. Her surgical breast reconstruction work is recognized as some of the best in Hong Kong, and she was instrumental in establishing breast-conserving surgeries and breast reconstruction within public hospitals. In addition to her far-reaching clinical work, Dr. Chung established the Hong Kong Breast Cancer Foundation in 2005, which then established the Hong Kong Breast Registry in 2007. This registry is the most comprehensive and representative data collection and monitor system for breast cancer in Hong Kong. Findings provide insight and evidence to support our advocacy for better prevention, detection, and treatment. In May 2014, Breast Cancer Hong Kong Online was launched. It is Asia's first local online breast cancer database and enables access to the registry data by medical professionals and to facilitate informed treatment decisions and prognosis assessments. Dr. Chung is currently the Honorary Director, Breast Care Center, Hong Kong Sanatorium and Hospital, and Honorary Clinical Associate Professor of Surgery at the University of Hong Kong, and is the current President of the Hong Kong Society of Breast Surgeons. Let's welcome Dr. Polly Chung.
Good evening, ladies and gentlemen. It's really my great honor to be here to share with you what we have done at the Hong Kong Breast Cancer Registry for the last 7 years. As we all know, breast cancer is an increasing health burden in Hong Kong. About 12% of all cancers diagnosed in Hong Kong, out of 26,000 each year. And 1 out of 4 cancers diagnosed in women is breast cancer. And every day we are seeing 9 new cases, and 1.5 cases will die of breast cancer each day. So it has been the fastest ever increase in incidence of cancers in women. So as Professor Sylvia Chan has talked about the Hong Kong Cancer Registry, it shows that the top 10 cancers in women in Hong Kong, the first is breast, followed by colon cancer and lung cancer. Our last data in 2011 shows that there are 3,419 cases of invasive cancer
and another 400 cases of in situ cancer, which is not counted in the cancer statistics here. So the lifetime risk is worked out to be 1 in 17 for invasive cancer, and if it includes in situ cancer, it will be a 1 in 15 lifetime risk for women in Hong Kong. So this graph, you can see that the breast cancer incidence rises from the 90s up to now in the 20s. In the 2 decades, it's increasing all the time and out of proportion to all the other cancers. So why do we need breast cancer registry? The management people have the jargon that if you can't measure it, you cannot manage it. So cancer registries are the eyes and ears of cancer control around the world. And in 2006, the World Cancer Declaration in UICC, which Professor Sandy is now heading towards to attend in Australia, has a call for increasing the number of countries with cancer registries. So what is the scenario now in the world on cancer registries? It covers about 1/6 of the world population. It was first established in the 1930s in the US, Germany, and Denmark. There's an International Association of Cancer Registries, which was founded in 1966 and review global data once every 5 years, and currently have 500 members. And we are, apart from the Hong Kong Cancer Registry in Hong Kong Breast Cancer Registry is also a member of the IACR. So what about the types of cancer registry? What is the difference between them? The central registry, like what we have in the Hong Kong Cancer Registry run by the Hospital Authority, is a population-based registry and produce statistics on incidence and mortality. So as what Professor Sandin said, this is a tumor-based registry. Cancer-specific registries maintain data on a particular type of cancer with a lifetime follow-up. So this is a person-based registry, and there is a longitudinal follow-up of all the cancers. Healthcare institution registries for academics, we all know that we used to set up database for our own patients with our own research interests for different types of cancers. And, but we don't have a central reporting system to our cancer registry, which is run by the government. So this is a non-government initiative operated by the Hong Kong Breast Cancer Foundation since 2007, and with the blessing of the then Secretary for Food and Health Bureau, Dr. York Chow, who encouraged us to take on this project and kick it off. So it has been the first of its kind comprehensive cancer-specific data collection and monitoring system. And as we see, we record risk exposures, disease pattern, treatment trend, and outcome, and also the physical and psychosocial impact of the cancer on patients. So this is very patient-oriented as well. So we have more than 13,000 cases collected so far, and we also emphasize on public access to the data and analysis. So these are all published in annual reports and also in-depth analysis and bulletins. So our mission is to provide vital data and analysis and insights for medical professionals, policymakers, for NGO advocates and the wider public to advocate and design plans for more effective cancer control. It also hopes to help bring about changes in public policy and medical practice to improve breast cancer care in Hong Kong. And also, as a first cancer-specific registry in Hong Kong, we wish to set a model, if this is successful, for other cancer-specific registry to guide our cancer control plans in Hong Kong. So our objective is to analyze the causes and risk factors of local breast cancer, to identify disease and treatment trends in local context, and to evaluate the impact of breast screening and early detection, and to advocate and support people-oriented public health policies and developing an improved standard of care for breast cancer patients in Hong Kong. We do have a large steering committee consisting of surgeons, medical oncologists, radiation oncologists, clinical oncologists, pathologists, and public health specialists. And we have IT consultants and also legal advisors. And most important is our patient representative in the steering committee to guide us what we should be doing. And as Professor Sandy mentioned, it is an opt-out for them in Sweden. For us, it's an opt-in. So we have consent forms, and we have collaborations with different hospital hospital clusters, and our data team will go to the individual oncology departments or surgical clinics, and the patients are referred to the breast cancer registry booth, and our data team will collect and get patient consent to be entered into the registry, and also to take questionnaire, especially on the risk exposures and epidemiology data. So we have about 300 data items in the whole breast cancer registry. And this database is set up by the initial steering committee. All the oncologists, surgeons, pathologists, and public health specialists, and also psychologists work hard and with almost like 10 times or 10 different templates and come up with the final one, which we hope to be simple to fill in, not too time-consuming, but also informative. Because all the correlations between different parts of the items will give us valuable information. So we have 3 parts. Part 1 is on the personal information, lifestyle, health background, family history, reproductive history. And the part 2 is on the disease characteristics and the treatment modalities and treatment trends. And the third part is the physical and psychosocial impacts of breast cancer on the patients, because we think this is very important. What we're treating for our patients, we hope they will get over the cancer and recover from it and go back to the society and work as normal as if they have not had cancer before. So we also have longitudinal follow-up on patient status, which will provide us with clinical outcomes. It will be the first time that we record true recurrences at either local, regional, or distant recurrences, and also the survival data on the patients. So this is a big system, which is a service system, and I'm glad that Dr. C.K. Wong is here. This is the very important IT provider for the whole system, which we have been working well for the last 7 years and without any problem of leakage of personal information and so on. And also any duplication of data. These are all validated. So we have annual reports produced and also bulletins to provide us with insights into information from the data registry. So we started off having only 1,000 cases when we first started off in having private clinics and surgeons and oncologists join in, and then subsequently more public hospital patients join in, and in the last report just released in September this year, we have 12,345 cases, and the next year we hope that we can go up to 15,000. So it's all spread out in the whole of the territory. And obviously, we hope that we can aim for a territory-wide percentage participation. We may not be able to achieve a 99% registration like what Professor Sandlin has been doing in Sweden, but we do hope to work towards a larger representation. So currently, it's a 70% to 30% break between the private and the public and the private healthcare entry of patients, and it is about 40% coverage of the figures that the Hong Kong Cancer Registry recorded. So we're ballparking the denominator with the Hong Kong Cancer Registry, which records, I think if it's not 100%, it will be 99.9% of all cases in Hong Kong through pathology reports. And we know that in Hong Kong it's a mixed healthcare facility user. So in our registry, about 60% are private healthcare services only, and about half of the patients come from the public health services only, and about a third of them has both mixed care from both private and public health services. So what do we learn from the breast cancer registry? It is the first foremost comprehensive picture of breast cancer in Hong Kong involving multiple centers that has all this information available to us, especially as clinicians. We are excited about it. And in Chapter 1, the risk exposure and so on, we found that almost 70% of the patients that we are dealing with is between the age of 40 to 59. And obviously, most of them are female. This, from the Hong Kong Cancer Registry, we know that only 0.5% are male patients. We do record a lot of things, and we know that from the data, about half of the patient, in fact, comes from the territories. In the Hong Kong Islands, only 16%, and a quarter comes from the Kowloon Peninsula. The size of breasts that we are dealing with in our breast cancer patients, you can see that over half of them are cup B or smaller, and the size is between 32 or 34 inches, is about 50% of the patients. So we are dealing with smaller breasts, so our characteristics of handling lumpectomies or plastic surgeries will be different from the Caucasians. And we identified 10 most common risk factors, and to our surprise, that the lack of exercise, which medical professionals have been emphasizing on doing exercise on the average 4 hours a week, and we found that over 76% of the patients do not have exercise more than 3 hours a week. So this is a major factor. Two-thirds of these breast cancer patients do not have breastfeeding. Obviously, with the age of 50 and 60, when they have cancer, when they were young, this is the age where people used to have bottle feeding instead of breastfeeding. High level of stress, we have definitions for it for patients to record, and more than 50% of the time, a third of the patients said when they live in Hong Kong, they have this high level of stress in a third of the patients. Overweight and obesity in 1/3 of the patients, and all the others. So identification of these 10 most common factors allow us to know what is happening in our breast cancer patients, and we have a joint collaboration with the Chinese University of Hong Kong School of Public Health and Primary Care to do research on this data, and we have already completed our case control study on these 13,000 patients matching with normal populations, and hopefully by next year we have some information coming out whether the lack of exercise is currently uniform among all Hong Kong people or whether it's specific for breast cancer patients. And in chapter 2, we look at the medical information. So we found that in fact 85% of our patients are self-detected cancer, meaning that they accidentally discover some abnormality in the breast and come to see a doctor. Only 9.4% are mammography detected cancers, and some others are incidental discovery. So it's very different from Sweden. They have 50% screening detected cancer, probably because of the population-based screening launched by the government. We have opportunistic screening by some centers in hospitals and also by NGOs and also by both universities. But the pickup rate is very small. And so a majority of cancer we see are really accidental discovery of the cancer. So obviously a painless lump is the most common symptoms that patients come to see a doctor. Over 90% are painless lumps. And we also found that we also record the onset of symptoms to the first medical consultation to see whether patients delay themselves in seeing doctors. And we found that about half of the patients will see a doctor within 3 months. But there is still a 12% of people who go to see a doctor almost like 12 months, with this more than 12 months when they have symptoms. There's a lot of unknown, and it's obviously because when we are recording the information from our hospital charts, especially in other hospitals and college department, this information will be lost on treating the patients. And from the registry, it's also very easily seen that right in breast tumors is the same. Some people say, oh, all my friends are left breast tumors. Is it right? So this data will tell us that it's equal. And it's also interesting to see that there are almost like 9% of patients with bilateral breast cancer. Half of them synchronous, meaning that they come at the same time with bilateral cancer presenting to a doctor, and some have subsequent cancer in the other breast. So this is quite a significant number of almost like 9% of bilateral cancer in our registry. We also record the diagnostic test. You can see that the overall sensitivity of mammography, which we always think is not accurate by a lot of GPs and so on, is 80% accurate in identifying the cancer. And obviously for breast ultrasound it's more, it's almost like 90%. It's because most of the patients come with a self-detected palpable lump, so obviously the ultrasound is more accurate. But we do have studies inside that shows in non-palpable cancer, mammography pick up more cancers than ultrasound. We also look at the diagnostics tests and whether corneal biopsy is often used and so on. And for a small percentage, excisional biopsy will still be needed to be used. This is very interesting. You look at the methods of cancer staging. You look at PET scan. 23% of people have PET scan. So I think it's quite high compared to the rest of the world. So are we overusing it? It's something that we can look at and to see whether we should not be ordering so many PET scans for early cancer like stage 1 or no-negative cancers. So for the cancer stage, you can see there's cancer. We are seeing mostly patients in the stage 2 cancer. 40% of patients are in stage 2 and 30% in stage 1. We do have 11% of stage 0 cancer and about 15% in stage 3 and 4. So this distribution gives us a peak at stage 2, which I think is not satisfactory as the clinicians from our viewpoint. And you can see the tumor between 2 to 5 centimeter is almost like half of the patients between this size. And so there's something for us to improve on in the future. And we have 60% of negative patients, but there's a substantial 40% of patients still coming with lymph node positivity. So it's, we all know that with node positive, as what Dr. Sandlin has mentioned, they will obviously go for chemotherapy, and this is a very heavy health burden for the government and for the money to be put into chemotherapy, and not to talk about the side effects of chemotherapy on the patients. And we record all the histological types of invasive cancer, which is probably the same as what is reported in the Western countries. And we also see grade 1, 2, and 3 cancers. Grade 3 is a third of the cancers. We also see multifocal tumors, which is up to about 10%, and multicentricity is about 2.8%, and lymphovascular invasion about 30%. So all these are very important information for clinicians, for us to know what is happening to our patients as a whole in the territory. And we can also see that for the estrogen receptor positive cancers, it is about 77%, which is a little bit lower than the 80% that is reported in Sweden. And we have a 23% CRP2 positive cancers, or HER2 positive cancers, and for Ki67 index, which we also record in most of the centers, in both public and private, we see a big proportion of patients having a high proliferative index, which is defined as more than 14%. So we do record biological subtypes including luminal A, luminal B, HER2 positive cancers, and triple negative cancers. You can see from here. So that's why I can answer Professor Sandlin very quickly that this is 12% we have triple negative cancer. And also guide us to our treatment, what drugs we are using, and how much resources we are putting in on these patients who will definitely need chemotherapy when they are bigger than 1 centimeter. We also record surgical operations. You can see from here that the breast conserving surgery rate is only 1/3, 35.1%, which is very low compared to in Sweden, which is 80%. So there's a lot of things affecting this outcome. Obviously, our tumor size is bigger, and whether our smaller breast would prevent us from doing breast conserving surgery on our patients, even with smaller tumors, are something that we can look at. And we also look at the reconstruction rate, and you can see that among the 7,500 mastectomy patients, about 1,000 patients have reconstruction. So this is a very low pickup rate for our patients with mastectomy. And in sentinel biopsy, about 50% of patients go for central biopsy. They're very different from in Sweden, which is almost like 90%, and obviously it's because of the earlier staging of cancer in Sweden than what we see here. We also record the treatments. Nowadays, breast cancer treatment is also multimodality. It's not only surgery that take care of the cancer. Obviously, it is early cancer, surgery is the most important thing. But you can see that among our patient cohort, 60% needs chemotherapy, 62% needs radiotherapy, endocrine therapy in 67% of patients, and 7% of targeted therapy in our patients. So this shows that the multimodality treatment is in fact costly for our patients, especially if they have a worse staging or no positive cancers. And you can see also here that if it's a stage 1 cancer, the use of chemotherapy is less than 40%. Very different. Once you go into stage 2, even with no negative disease in stage 2A, it's go up to 80%, more than 80%. So not to talk about stage 3 and 4 diseases. And we also know that with recurrences or distant recurrences, patients with breast cancer live for a very long time, not talking about months, but talking about a 5-year survival for stage 4 cancer being 20%. So all these patients are using up a lot of resources, whether it's from the public hospital or from their own pocket of the community resources on treating these patients. And you can see that in the public hospital, chemotherapy is treated in the public in 84% of the patients, about 15% in private. And we also record the type of chemotherapy regimens, and this is something that we record for future analysis of the utility relation to outcome. Because we know that there are a lot of differences, as what Professor Sandlin mentioned, in different counties or different regions, you have probably slightly different treatment. Although Hong Kong is very small, but in different oncology hospitals, we have different regimens. And so which regimen is the best? We don't know. And time can tell us. Our information with the outcome in recurrences and survival can tell us which is the best way to treat our patients and which is the most economical and chemotherapy regimen with the best outcome. And radiotherapy, again, 85% is treated in the public and 40% is treated in the private. And again, you can see that in stage 0, obviously, you have a lumpectomy with they are also incorporating radiation afterwards. So for stage 0 and stage 1, usually about 50% of patients would have radiation. But once you get into the no positive cancer, you have almost like 80 or 90% of people requiring radiotherapy, which is a very heavy burden on our radiation systems in both public and private hospitals. And endocrine therapy, as mentioned, again, it's all the oncological treatment, about 85% are in public and about 15% in private. And we do have a good follow-up of these patients, and the median follow-up period from last September is 4 years. And we hope in next year we'll have a median follow-up of 5 years, and it will be time for us to do trend analysis and also to look at our recurrences and survival data with a median follow-up at least 5 years. So we do record local regional recurrences, distant recurrences, and also the time from treatment to recurrence. So this is very exciting information for clinicians because we can understand and know what is happening to our patients and our outcome as a whole group and not just an individual or individual hospital even. So patients' perspective is very important in the registry, so we record the physical and psychosocial impact on the patients. And we see that surgery, about 16% complaints of wound pain, and most of the patients, 2/3 of the patients said that it's minimal discomfort or no discomfort. But radiation, again, minimal, no discomfort is 2/3 of the patients. But coming to chemotherapy, is just the reverse. Almost like 60% of patients will complain of severe discomfort with all different symptoms of vomiting, loss of appetite, hair loss, weakness, and loss and so on. For the psychosocial aspect, we look at patients with young patients compared with the elderly patients, and we found that younger patients, it's more difficult for them to accept the diagnosis of breast cancer, which is very obvious. And you can see the green bar. For those with the elderly patients more than 70, most of them accept calmness and also positive attitude. But you look at the red bar in the young patients group, the left side, you can see that a lot of them cannot accept it or accept it with anger or depression. And although they are more difficult to accept the diagnosis of breast cancer, also they are more worried about recurrences, being young. And so you can see the red bar, they're always worrying about it. So we know what is the psychological impact on this group of patients. While they are the working force or the mothers at home, they are the pillars or CEOs of the family or in their work. And but they would change their value system very quickly, and they would also change their lifestyle in a positive attitude more than the elderly patients. So change of diet, change of lifestyle, meaning more exercise, and some quit their job. So this is a loss to the community if they do quit their job, and some will reduce workload as well. So this is a very interesting information from our register. Although the younger patients are more angry about the diagnosis, they do have a more positive change in outlook. And in the elderly patients, many of them have no change, and most of them, either no change or positive change. I think our longevity for women in Hong Kong is at the age of 86, and some people will think, oh, I'm near the end, so I don't worry about it, my children are already big enough and so on. So there's a very big difference between younger and elderly patients. So Breast Cancer Hong Kong Online is a very exciting thing for us, and I have to thank Mrs. Santa Wong, who has been very supportive for our launching of this program. This, as you see, we have been issuing annual reports, so these are black and white reports. You can only read them once a year. But Breast Cancer Hong Kong Online is an interactive system. All the information are there. If a patient comes to you and with 48 years of age, with a 3-centimeter tumor, what is being treated by the doctors or what is being treated by other doctors in a peer group, the doctor can just enter the information and get what is happening in Hong Kong. And this is our first step, which is phase 1. We look at the treatment trend or treatment pattern in Hong Kong. The phase 2 trend we'll look at will be the survival and recurrence data. So this is a very important information. We are being always asked by our patients, what is my chance of survival? Am I going to recur? So at least we can tell them if this comes along, what is the information that can help us to decide what is being treated, what is going to be treated for the patient. So we learned a lot of things from the breast cancer registry. Just to quote a few examples, is Hong Kong breast cancer picture different from the West? So you look at it, Hong Kong, our median age is younger than what Professor Sen had mentioned, and our age group is between the age of 40 to 59. We have screen detected cancer only 9%. In the States, it's about half, and also in Sweden, we learned that it's 50%. And this is a register, which register all the countries with population-based breast screening in Hong Kong. And if we look at our cancer stage for Canada, who has a national screening, a free mammography screening, the brown bar, the highest is stage 1. But for us, in the blue bar for Hong Kong is stage 2. So there is an earlier shift of staging for people who have systematic screening. And this is probably not very different. And if you look at the public sector and the private sector, we can see that in the public sector, only 5.7% are stage 0. And for stage 3 and 4, it is 18% compared to 13% in the private. So there is an earlier shifting of staging in private. Obviously, private has more screening habits in the women who are better informed. And we do see the size of tumor, there is a difference as well. And the breast conserving rate is also different in both in the public and the private. So you can see 34% in the public and 66% in the private. And this is the reconstruction rates, and and also we study the cancer staging in relation to the patient background and screening habits. And we found that Hong Kong Island patients have a higher screening habit, and the staging is worse in low-income districts. So this is some study that we've done before, showing low-income areas with higher, with more advanced staging, and this is related to their screening habits as well. And so this is a lot of work in the registry, but it shows very valuable information. And in the end, we conclude that we need to do more health education work to low-income districts of women in Hong Kong. And we also look at differences between self and screen-detected cancer. We found that screen-detected cancer has a smaller tumor size, earlier stage, less nodal involvement, less mastectomy, and less chemotherapy. So this is seen for people over the age of 40, which we would advocate to start screening. And you can see the blue bar could is screen-detected cancer with more stage 0 and 1 cancer than the self-detected cancer. And the median size of tumor in self-detected cancer is 2.3 centimeter, which is 1.3 centimeter screen-detected cancer. So it's earlier staging, probably something like what's happening in Sweden. And the no positive rate is 42% versus 21%. So it is double-fold of nodal involvement if you detect your cancer incidentally. And also the breast conserving rates, you can see that in the self-detected group, you have more, less breast conserving than the screen-detected group. And also the chemotherapy usage is 66% versus 25%, which is a 3 times higher use of chemotherapy for self-detected cancer. So all these are statistically significant. We're working on the data, and we hope to produce peer-reviewed submission in the future. And we also, interestingly, we look at the delay in cancer presentation medical treatment, and we found that self-delay is more important than medical delay. That means that patients who have symptoms, they ignorant about it, and they may have it for several months or more than 3 months before they see a doctor. And we found it from the registry that a delay for more than 3 months will give you a larger tumor and also more nodal positive cancer and more advanced cancers. And care delay, we are still within our international standard, you can see in subsequent slides. And we identify groups of patients who have more self-delay, which are the labours, widowed, and also patients with benign breast disease probably have more sense of security when they have the experience of benign disease before. So the median time of time interval between the first symptoms to medical consultation is 40 days, and you can see the bracket area where they seek a doctor only more than after having symptoms for more than 3 months is almost like a third of the patients. And if we compare to other countries, the median time delay for us, 40 days, is better in Malaysia, but compared to Western countries, we are far behind. And so all these are very interesting data. You can read it in our bulletin. It's all in the bulletin. I just took out a few slides. And also there is a difference between public and private patients. And also with delayers, you have bigger tumors and positive nodes and more advanced cancer, which are all statistically significant. Yeah. And but for the first medical consultation, the first treatment, we are still within the international standard, but we found that diagnostic delay is more than treatment delay. That means that the patient comes to you with symptoms, you diagnose it. It takes 60% of the time consumed is on diagnosis. So that is a bottleneck in our system, especially in the public hospital system, I think, because of the x-rays and biopsies and so on. And for confirmed cancer to first treatment is less than 1 month in 80% of the patients. So we are still doing okay in this aspect. So this is some kind of indicators that will guide us to make sure that we are doing our best for our patients. So for this, we can see that breast health education should be emphasizing on alerting the public to what is the signs of breast cancer, what are the things that we have to see a doctor promptly. And also, if there's some abnormality, you have to see a doctor less than 3 months and not more than 3 months. And the bottleneck in diagnostics should be addressed to avoid delay in our medical treatment. So there are more knowledge or information to be uncovered in this breast cancer registry. It's a huge treasure of information that can guide us in future for improving breast cancer prevention, control, and treatment. So thank you.
Thank you, Dr. Palishan. You may now be seated. At this moment, I would like to invite Professor Martin Wong to be the moderator for our Q&A session. Professor Wong is an associate professor at the JC School of Public Health and Primary Care, and director of the CUHK Jockey Club Bowel Cancer Education Center, and associate professor at the Chinese University of Hong Kong. Let's invite Professor Wong to come forward to begin our Q&A session. In the meantime, I would also like to invite Professor Sandelin and Dr. Chan to be seated at the front for the Q&A session.
Thank you very much. I was asked by Professor Ali Chan to participate in the coordination process. I think perhaps the message that family would like to bring across would be the only male who participate in the on the stage. So both female and male health practitioners should participate in the fight against breast cancer. And may we give another round of applause to our distinguished speakers. Dr. Sandelin and also Dr. Palishan. We are very happy that Professor Sandelin has actually described about the very comprehensive breast cancer registry in Sweden, which is national-wide, and also covering the whole population, about people aged 40 to 75 years old, and how we can actually prevent cancer from the public's and the patient's point of view, as well as the importance of regional and national reports. We are also very amazed by the very detailed information in the Swedish breast cancer registry, and this is one point where we should probably really learn from the academics as well, from both practitioners as well as the policy makers. And we are also very happy to learn from Polly today about the burden of breast cancer in rising very sharply, and we are very worried about its increasing trend. Yet the presence of the Hong Kong Breast Cancer Registry, which is territory-wide and covering lots of aspects, really helps. So from the slides, we can see a lot of very rich information covering clinical parameters as well as a number of patient-centered clinical outcomes. So I thought both speakers gave us very, very useful and informative data, and also they're sharing very valuable as well. So without further delay, so how many minutes do we have now? I think a number of us are hungry, yet we are also hungry for answers as well. Perhaps we can take any first questions from our audience. The floor is now open, and I'm sure you have some questions. Must be some questions. Yes, our lady. Yes.
start by asking Professor Sandelin. You've mentioned more than once about target levels in your registry. Can you tell us more about that? What exactly are they?
Thank you. This was something which we initiated in the 2012 report. We thought that it would be useful for the readers to know what are target levels for each modality of treatment, and also for the lead time. So the target levels are set by international and national standards. And as I mentioned, both from the Swedish Surgical Society, like for example that 9 women out of 10 should have a confirmed breast cancer diagnosis at operation. So the operation should not be diagnostic. The waiting times, Polly said not more than 3 weeks before you initiate treatment. That's another quality indicator. A third one would be there should be a contact nurse to have as the patient, like a patient navigator. So they were set by, as I said, by surgeons, by the Swedish breast cancer group, by EUSOMA guidelines, and I think also by Europadoma.
Thank you.
Right. Any further questions? Yes, Shelley, please. Shelley.
This question is to Dr. Polly Chan. So my question is that is it possible for Hong Kong researchers to request for the data set, researchers for data set for writing papers for further research, just like similar situation like Sweden, so open for national request, national application. Thank you.
Definitely. When we have the consent from our patients, the consent includes collaboration with institutions in Hong Kong for doing research on an unnamed basis, so it's open.
Right, so that's great. Yes, gentleman in the middle.
Yes, I guess I have a question. Thank you, Polly, for doing such a good job in presenting your findings. Well, we can see that in Sweden, mammography is covered by the government, whereas in Hong Kong it is not. In the United States, where I used to work, all insurance companies cover mammography, and all the women are encouraged to take advantage of this coverage. Your study has already shown why these women most of the cancer was detected by themselves, and rather than by screening. And also, you show that a lot of the women actually come from the women from the lower income group. They lack maybe they don't want to spend the money on mammography. And I think towards this end, I think your Breast Cancer Foundation has a duty to push the government and all the insurance companies in Hong Kong, show them the data and tell them that they better get started. We're way, way behind. And I think you will do much better by using this data and push it along the line where you can actually get something to happen.
Yes. So, Polly, any feedback? This very interesting, important question.
Yes, this is very useful information because we are not following the Western practice blindly, but this is local data that will show us whether there's any difference. So we're working on the data to make it into a peer-reviewed submission so that it will be a validated data and not just a simple description. And also at the Breast Cancer Foundation, we hope to help as much patients as possible, help the women at large. And that's why we have set up this breast health center in the foundation, providing free mammography service to women, to underprivileged women if they pass the means test. So this is being supported by the Hong Kong Jockey Club, and we have been going into the 4th year of service for women in Hong Kong. And we're also planning to have a Kowloon Center. We have a Hong Kong Center, hopefully to expand the service into Kowloon, which is where the most patients from low-income districts will be residing. So these are the work that we're doing. And we can say that we are the information provider from the foundation, which is very strongly supported by a lot of clinicians, including oncologists, surgeons, pathologists, and public health specialists. But lobbying is the job of our of our legislator. We will provide all the information necessary, and hopefully they can take up their voices to the.
Who is the legislator?
Legislators' involvement, right? Any further questions? Well, I have one question for Professor Sandlin. The compliance of breast cancer screening in Sweden is actually very, very high. It's 75 to 80%. And yet we learn from literature that persistent compliance over time actually decline quite rapidly. So are there any measures or interventions which can ensure the compliance over time is also stable and at a high level?
Well, thank you. Because we've had screening for such a long time, it is true that it has decreased somewhat. I think one of the initiatives, and we set target levels also in the inventory of the cancer strategy, and we actually set it for 85%, because also of the opportunistic screening. I also have to admit that it's not totally free mammography screening, but we did change it a few years ago, so it became free. But it's also something which is decided on the county level. So women in the Stockholm-Gotland area, they have their mammograms for free.
Right. Thank you very much. So we see whether there are further questions on the floor. And yes, may I ask one more question for Polly, please? In Hong Kong, we know that population-based screening is actually recommended among high-risk group individuals. So actually to kickstart population-based screening for breast cancer in Hong Kong, what would be your recommendation based on the latest evidence?
Well, in fact, I can quote the Department of Health policy from the Cancer Expert Working Group in Hong Kong in 2011 or 2013. They released a pamphlet. For high-risk people, it's defined as people who have family history, people who have personal history of breast cancer, and also they interestingly include people with benign breast disease, and also gene mutation carrier or child radiation to the mental. All these are considered as high-risk people, and they can go for mammogram screening, or they can consider mammogram screening once every year. This is the government policy. So I'm glad that this is a very big step forward from 10 years ago in 2005 when we first set up the foundation. At that time, the recommendation is against mammogram screening in any woman of any age. So this is a kind of advancement from our government side. So in fact, in our current center, which we are applying for land from the government, hopefully we can be a center dedicated to high-risk people screening.
Yes, I think the center would like to also supplement as well.
Yes, could I ask you, Polly, first of all, I'm deeply impressed that you get your results out so quickly, where, as you can see, we don't. So that's my first question. And my second one, how do you validate your data?
We have a very dedicated research team, which services the whole of all these centers in Hong Kong. So it's not that it will take away eliminate the individual or regional differences between the hospitals. So the team works together. Any new members that join in, they sign the same confidentiality statement, everything. So they go to all the different hospitals and clinics and get the data. And these are all staged when they have the raw data in. And then we have the validation to make sure that all these are consistent before they will be put into the registry. As we call it, a staging area, when all the information comes in. Dr. Wong will be the best to know about it. And then we put it into the registry for analysis only after they are all cleared and validated.
So you do
very stringent process.
Re-abstraction at times? The re-abstraction is when you take an empty form and you do it again and you see if you get the same.
From the same patient?
Yes,
No,
yes.
that we don't. No, that we don't.
We are actually conducting a validation study in Sweden now in order to see, because we found that some variables were difficult to comprehend, that there were interpretation problems, and that is why we thought that the validation would show us which variables were unclear, and we go around in Sweden and we meet with the different people who actually do report, and they bring up problems or questions where we don't know how to interpret this question, we may fill it wrongly.
We have a whole data manual with all the definitions, so all the data officers have to read them and know them by heart when they interview the patients. One thing which I think you bring up is very important is the templates. You can see that we have a lot of missing data in some of, say, like first visit to see doctors, how many months and so on. All these are missing data. And if we can have a template of when the first time the patient comes to see a doctor, these are the data that will be filled in. And hopefully this can be integrated into the electronic medical systems in the public hospital system as well as in the private hospital, hopefully. Then we can have a one press of a button, things will go into register, like what you have. This is my dream as well.
Yes, let's see if we can take 1 or 2 more questions or... Well, I can see that the food are actually ready, and I'm sure everybody agrees that both our speakers have given us a very, very fruitful and also very informative talk tonight, as well as interactive sessions. And let's give them another round of applause. And thank you so much. And I'm sure you can actually also communicate with them during dinner time. They will be more than pleased to actually answer your questions. So thanks once again. So let's enjoy your dinner. Thank you.
Also put your hands together for Professor Martin Wong for being a great moderator. We will take a short break and we'll see each other again after appetizer for some souvenir presentations. Ladies and gentlemen, I hope you're all enjoying your dinner. Can we please pause the meal for a moment, and I would like to direct your attention back on the stage. We'd like to invite Professor Samuel Wong, the professor from GC School of Public Health and Primary Care, as well as head of our Division of Family Medicine and Primary Health Care, to come on stage, come forward, and present souvenirs for guest speakers. Let's put your hands together for Professor Samuel Wong. First, I would like to invite Professor Sanders to come forward to accept our first souvenir. That's it. Face forward and maybe forward together. Smile. Samuel Wong. Thank you very much, Professor Sanders, for your valuable time. Oh, one more picture. Thank you. Now be seated. We would also like to invite Dr. Polly Chung to come forward to receive our souvenir. Let's give him a round of applause.
Slightly before my time. Yeah, just slightly before. Would you?
Thank you. One more picture. Let's take a group photo.
Oh, wow. Brutal. And it's supposed to be a real story. It's a real story.
Thank you, speakers, and thank you, Professor Samuel Wong, for presenting the award for us. Finally, I would like to invite Ms. Lorna Wong, representative on the steering committee of Hong Kong Breast Cancer, to give the closing remarks. Put your hands together for Ms. Lorna Wong.
On behalf of all of us here this evening, I would like to express our sincere thanks to Professor Sandlin and to Dr. Zheng for their insightful presentations and sharing experience in establishing breast cancer registries in Sweden and Hong Kong. We certainly have learned a lot from Professor Sandlin about the situation of breast cancer in Sweden. I would also like to thank Professor Sovic for delivering the opening remarks for us here this evening. Experience in Sweden and Hong Kong have effectively highlighted how and to what extent breast cancer registries can positively impact on the prevention and control of breast cancer within the community. As a member and in particular as a patient representative sitting on the Hong Kong Breast Cancer Registry steering committee, I can relate to many of the challenges highlighted by speakers tonight. The representation and collection of the data is certainly a challenging process. But the patient-supported side, the building of a representative registry requires careful planning and collaboration with health service providers in both private and national sectors. Accurate and scientific analysis can also to be developed to reduce perceptive findings useful reference and research by the medical profession, patients, policymakers, and I remember when I was diagnosed of the disease more than 4 years ago. Amidst the shock, fear, and confusion, I found the Hong Kong Breast Cancer Registry. I studied the report from cover to cover, as I wanted so much to know where I stand among the breast cancer patients here in Hong Kong. Well, there may well be loads of data about breast cancer patients in other parts of the world, but I wanted to know how my disease, say the size of my tumor, the biological and physiological characteristics, etc., measured against local patients in Hong Kong with whom I share the same living environment, the same gene pool, and similar diets. I found myself in the end being able to memorize the details of the report because every bit of it has been so informative and useful to me as a patient. Well, in the last few years, the Breast Cancer Registry has made considerable and significant progress in achievement. As Dr. Zheng has just highlighted, the number of patients registered has now reached over 30,000. The balance between public and private patients has continued to improve, and this growing pool of valuable data has enabled the production of informative analysis and findings about the characteristics and treatment plans for breast cancer in Hong Kong. Tonight, we are very grateful to the organizers of the symposium for facilitating such a useful exchange of experience between Sweden and Hong Kong. I'm sure all of you have learned a lot from the thought-provoking discussions. The success of breast cancer registries rely on the commitment and collaboration of all stakeholders, which include the government, the medical professions, the pharmaceutical industry, patients, and the community at large. The willingness of relevant parties from the private and public medical sectors to cooperate and to share information will lead to a more effective registry, and which in turn will become a powerful tool in our battle against breast cancer. Thank you very much for joining us this evening. A special thanks again to our special guest speakers this evening, to our co-host, the Hong Kong Breast Cancer Registry, and to our generous sponsor, Roger. So thank you very much, and please enjoy the rest of the evening.
Thank you very much, our patient representatives from Guanawang. Ladies and gentlemen, on behalf of CUHK Hong Kong for Global Health and Hong Kong Breast Cancer Foundation, I would like to thank you for joining us this evening. We hope you will continue to enjoy the food, and we had some excellent talks. And feel free to continue to stay. And thanks again, our guest speaker, Professor Sandlin and Dr. Polly Chung, for sharing with us tonight.
Where did they go to school?
Just a reminder before you go, the CMB and CME are ready outside at the reception. If you haven't signed in, don't forget to do so before you go. Once again, thank you very much for coming. We hope you enjoyed the evening, and good night.